focus of today's session, we'll go through some of a few differential diagnoses, so what you should be thinking of when a patient comes in with headache. And then we can go through a bit more in detail about the kind of questions that you will ask to find out what the cause is likely to be. And then we'll go through a few investigations, examination, and also management of a particularly dangerous condition causing a headache, which is subarachnoid hemorrhage. So we won't have time to go into management of everything, but I'll just touch upon management of subarachnoid hemorrhage. Fine, so just quickly going through the differential. So if you see again, in an OSCE setting, if you see on the door that there's this 50-year-old patient who's come in with a headache, you should already, in the 1 minute that you have outside, you should already be thinking of differentials like we've spoken about previously. So in that case, when you're outside, in your head, a good way to divide your differentials would be things that are very dangerous and you should rule out. So things like vascular causes, so subarachnoid hemorrhage or subdural hemorrhage, temporal arteritis, infective causes such as meningitis and encephalitis, and malignancy, so brain tumors as well can often present as headaches, even in young patients, so it's one to look out for. And then you also want to think about the not so dangerous but the common causes of headache, such as tension headache, which is the commonest cause, migraines, sinusitis, cluster headaches, and trigeminal neuralgia. Yeah, that's fine. Perfect. So and as you can also see, I've just divided the dangerous causes just into three. Well, so it's called a surgical sieve, and this, I think you may have heard me say this previously, but classify or die is one of the strategies that I've used previously, and that's pretty useful. So, and it's a good way to ensure that you don't forget anything. So if you have headaches, if you have things like constipation, it could be any presenting complaint. If you try and divide the differential into vascular, infective, inflammatory, malignancy, it would just mean that you give the patient a very thorough approach and don't miss out on anything. So this is just an attempt of me categorizing the dangerous causes of headaches, so vascular, infective, malignancy. Fine. So in your history, this can be quite tough to do in 10 minutes. So it's very important to kind of gauge an idea. So when you ask your open-ended question, could you describe the headache for me, or could you just talk me through an episode, or what happens when you get the headache? Just try and get a feel of what the type of headache might be like, and then definitely rule out the dangerous causes. So we'll just go through how we do that. So firstly, so just the overview of the history that you will be taking, you first want to do a Socrates. So I don't know if you guys have heard of, so I think the majority of you would have heard of it, but we'll go through that in detail. And then after you've done your Socrates, you want to cover the red flag symptoms. So this is very important. And then, because headache, especially if it's long-standing chronic headache, can actually have quite a significant impact on the patient's work and just their overall well-being. So it's actually very important just to kind of understand how is it affecting their life, is it affecting their life, and to what extent it is. And then obviously, as we do in all other histories, you want to cover your past medical, family history, social history. So yeah, let's go through the Socrates first. So yeah, this slide looks very crowded, but I will just go through every point with you one by one. So yeah, Socrates essentially stands for S for sight. So you want to ask them, where is the headache? Is the headache frontal? So if it's frontal versus if it's occipital, there are different causes. So occipital headache, if the patient says, oh, the headache is at the back of my head, it is already ringing alarm bells in your head, because this could be a subarachnoid hemorrhage, because it classically presents as pain at the back of their head. Okay, so you want to ask them if it's frontal or occipital. Frontal headache is, so things like, in terms of the dangerous causes, a brain tumor can cause a frontal headache. In terms of the benign causes, sinusitis or tension headache can cause a frontal headache. So but it's a good question to ask, where is the headache? And then you also want to know, is it bilateral or is it unilateral? So migraine and cluster headaches typically cause unilateral pain, okay? Not always, but in most cases it's unilateral. So again, if you ask that, you kind of have an idea of what it could be. And then you want to know the onset. So the O in Socrates is for onset. So did it come on suddenly? And this is one of the rules in medicine. If the onset of anything is sudden, you have to consider a vascular cause. So if the headache came on, bam, very suddenly, so sudden onset headache at the back of the head, you are highly suspicious of a subarachnoid hemorrhage. And then you want to know the character. So what does the pain feel like? So in migraines, they would typically say that the pain feels like it's quite throbbing and pulsatile in nature. Yeah, if it's like dull pain, it could be things like tension headache, it could be cluster headache. And if it's like a sharp, intense, burning pain, it could be things like trigeminal neuralgia. I'll go through what that is in just a bit. Yeah, so that's the R. Sorry, that's the C in Socrates. And then coming on to radiation, there's not much that radiation would point towards in terms of differentials, but you could just ask them, oh, does the pain move anywhere? It's just a good thorough pain history. And then coming on to T, actually, the A I've missed out because there's actually quite a lot to do in A. So when you do this headache history, I would recommend you kind of skip the A just for a bit and come to that later. Fine. So then going on to T, you want to ask them how long does the headache last for? Do you get them every day? So the frequency, how long does each episode last for? Because what you will find is in cluster headaches, the pain comes on at the same time, typically at night, and it will last for the same amount of time. And they can get these in like clusters every year. So the patient might say, oh yeah, I get this headache every day at 10 p.m. and I'm about to go to sleep and it lasts for 2 hours every day and I get this every year. So then you know that is pointing a bit more towards cluster headaches. Fine. And then you want to ask them, so the E is for exacerbating and relieving factors. So what makes the headache worse? This is important because things like brain tumors, which will cause a raised intracranial pressure, if you have a brain tumor causing the headache, the pain will be worse when the patient lies down. Yeah, and the pain is also worse in the mornings in this case. If the patient says the pain is worse when they're combing their hair, for example, it points more towards temporal arteritis. We'll go through what that is in a bit as well. If they say the pain is worse when they're eating or coughing, that points towards trigeminal neuralgia because the pain presents when it affects nerves, the trigeminal nerve essentially. And then you also want to ask them what makes the pain better. So in a migraine kind of headache, what makes the pain better is often sitting in a dark, quiet room. So if they say, oh yeah, I get this unilateral pain only on one side of my head, it's quite throbbing in nature, and it gets better when I go in a dark room and sit there, and it gets worse with loud sounds, it's pointing a little bit more towards migraine. Yeah, so that's your E. And then coming on to S. S is severity. Sorry, that's the last bit is just gone. But you want to ask them, how bad is the pain? Now, this is again important for not just understanding how the pain is affecting their life, which is also very important, but also, again, subarachnoid hemorrhage, they will describe it as the worst pain of their life. So you don't want to miss this question. Ask them, how, on a scale of 1 to 10, how bad is the pain? Just to give you an idea of how it is affecting their life, and also to give you an idea of the dangerous causes as well. All right, fine. So then coming on to your associated symptoms. So in this, because there can be actually quite a lot of symptoms to ask for. So if you just look at the slide with the causes, I've just kind of divided the associated symptoms in a way that you can basically rule out all these dangerous causes. Okay, so if you just take a look at that again, and I'll go on to that. The history slide. I'll just leave that there for a minute. Fine. Okay. Yeah, so the first dangerous cause was anything vascular, yeah? So things like subarachnoid hemorrhage, subdural hemorrhage. You want to ask them if they have had any head trauma. You want to ask them if they collapsed, because that points more towards a vascular cause. And again, if they say the onset of the headache was sudden, then you know it's more likely to be vascular, and you would probably order some imaging like a CT head. Okay, and then temporal arteritis. Now, temporal arteritis is dangerous because it can cause blindness. Okay, so it's very important to recognize this, and it is essentially it is a vasculitis of your temporal artery. It presents as vision problems, so it can cause double vision, blurred vision, and eventually lead to loss of vision and a headache. And actually, in this case, if you press over the temporal area, it is actually quite tender as well. And when you do examine the patient, which you will, you can actually feel, so you can't feel the pulse of the temporal artery because it's all hardened and stiffened up. So that's temporal arteritis, and it's important because it can cause loss of vision, so you don't want to miss this. It is more common in the elderly patient, so it's unlikely in a young or middle-aged patient, but just something to keep in the back of your head. So if they say that the pain is worse on combing their hair, for example, and if they do have vision problems, it is something to keep in mind. Fine. Then coming on to meningitis, this is very important. You do not want to miss this. So you just ask them for things like photophobia. To be fair, if they're sitting in a bright room with you, it's unlikely that they have photophobia. But yeah, just I guess they never. That doesn't hurt to ask. But just like there is a difference between true photophobia and false photophobia. Like some people might say that bright lights make their headache worse, which is quite commonly seen in migraine, but this is not the same as the photophobia seen in meningitis, where they literally cannot be in a bright room. Yeah. Fine. And then stiff neck, photophobia, fevers. Fevers are very important. It's very easily missed as well, so very important to ask about fevers in a headache history, and a rash as well. And then if you have time, you can always ask about unwell contacts, if they've just recently started university, have they been traveling anywhere. If you are suspecting meningitis and it sounds like it, then definitely go through it in more detail with these kind of questions. Okay, fine. And then coming on to brain tumors. So a brain tumor can cause things like seizures as well. So you can ask them, have they had any funny fits or turns in the last 2-3 months? Have they had any limb weakness? Because it can cause focal neurology. And then I've written FLAWS. I don't know if you guys are aware of this acronym, but essentially any cancer, if you are suspecting any cancer, or to rule out any kind of cancer, well, not to rule out, but to kind of make sure you've addressed cancer in your differentials, you can ask them fever. So that's F for fevers, L for lethargy, A for appetite loss, W for weight loss, and S for night sweats. So again, you don't have to ask them all 5 unless you're strongly suspecting it. You can just ask maybe, have they lost any weight, which is probably the most sensitive for cancer, and for example, are they more tired than usual? Which, fine. So that's brain tumor. Again, if you are suspecting more. So if you're suspecting that this could be a brain tumor, so in your Socrates, if they say, oh yeah, the headache is worse the first thing in the morning, and it's like I've had some weight loss as well, and I have a family history of brain tumors, and obviously this is like high up on your differential list, and again, you would order a CT scan to see if there's any space occupying lesion in the brain. Fine. And then I've just put migraine that it's not a particularly dangerous one, like not as dangerous as the others, but it is quite common, and you can actually, it's very important to ask about things like nausea and vomiting, and then also any aura beforehand, because it can also be like, especially when you see patients, they could have, for example, a migraine with an aura, and if in your drug history you find that they are on a combined contraceptive pill, that is contraindication. So you could always raise that up and be like, if you could go to your GP and basically stop taking the pill, because if you have migraine with aura, you should not be taking the combined contraceptive pill because it increases your risk of stroke. So for migraine associated symptoms, you can ask nausea, vomiting, like we said, and aura. So an aura can present as many different things. Common ones are things like flashing lights, and some people say that they kind of have this certain smell. It can be anything. It could be anything. It's very specific to every person. So what you could ask them is, do you know when the headache is about to come on? So do you get any kind of triggers? And when you know, okay, fine, I'm going to get my headache now. So that's a good question to ask for aura, because fine. So that's basically this. If you ask all these questions in your head by now, you should already be having a bit of an idea about what this headache could be. So let me just quickly give you a quick summary. So let's say the patient has tension headache. So in a tension headache, which is the commonest type, the patient would have pain on both sides of their head in the frontal region. It would feel like a tightness kind of sensation, very dull pain. It would be triggered. So what would make it worse is things like stress or fatigue would make it worse. And it would last only for a few hours and often get worse as the day progresses. Okay. For migraine, this would be a unilateral pain It would be throbbing in nature, well, more likely throbbing in nature. It would get worse with lights, with loud sounds. It would get better in a dark room. Patients can also have nausea, vomiting with it, and some patients may also have an aura where they can feel the headache coming on. So this could be flashing lights or things like smells. And a migraine can actually last from anywhere between 4 to 72 hours, actually. So yeah, it can be quite disabling for the patient. And then let's say, so I'll just go through another benign cause, cluster headaches. Some people may have heard of it, some people may not have, so I'll just go through it in a bit more detail. So this is, it's I wouldn't say it's common at all. It's fairly uncommon. It's more common in men than women. And it typically causes a unilateral pain, mostly around the eye region. And like I said, it occurs in clusters. So it may happen once in like 12 weeks. It may happen once in a year. And the headaches come on at the same time every day. So the pain is usually over just one eye. It can be made worse by things like alcohol. And it also, so the associated symptoms, I haven't put it down there, but it's also often associated with a red eye, watery eye, runny nose, those kind of things. The pain may last from 20 to 30 minutes and up to 3 hours as well, so also quite varied. And the pain is actually really bad. It can be a very severe, intense pain, and it's often made better by the person, it sounds strange, but it's made better by the person pacing up and down. So if you just imagine like a young gentleman in his 40s, for example, having a very severe pain, red eye, and he's just walking up and down to make the pain go away. That is your cluster headache. It's not, I can appreciate it's not good to often like put these patients in a basket and just, because in real life it can be very mixed, but it's a good way. So if you just kind of think of the main characteristics of each headache and just kind of imagine what the typical person with that headache would be like, it can be a good way to just get introduced to the various types of headache and how they may present. Fine. So that's just, if you just keep this slide and just screenshot it or something, and then you can use this as like a template for your history taking. I would again emphasize, definitely do not forget to ask the associated symptoms. So you have to address the dangerous causes or the red flag symptoms are very, very important. So I'll just go through them again briefly. You want to ask about signs of meningism, so that's your headache, fevers, rash, and photophobia and stiff neck. You want to ask them about any cancer symptoms, so that's your flaws, seizures or focal neurology, and you want to ask them about any vision problems as well, and any head trauma, because that could mean that could be a vascular cause. Fine, so I'll move on to the next slide, but if there's any questions, feel free to ask them in the Facebook group or wherever. I think on the YouTube channel as well, you could probably ask questions. Fine, so I'll move on from that. And then, so just coming on to the rest of the history as well, very important, like we've said before. So you want to ask them, is there anything that they're concerned about? Because if they've been having a headache for a long time, if they have a family history of cancers, they could well be, if they've also Googled, they could well be thinking that, they have brain tumors and they could be worried about that. So it's very important to ask what the patient is worried about so we can reassure them in the right way. Or if we are also worried, we could order the right test for them. You want to ask them how is it affecting their daily life, because like I said, migraines, cluster headaches can be extremely disabling and actually might even need psychological support, so it's very important to ask this. Past medical history, just going on to the previous point. Again, I appreciate that you may not have the time to do this in a 10-minute station, but again, everything, like in real life, very important to address these things. So I'm just going to tell you, just like, because it's good practice to do that, but again, do not worry if you feel like in those 10 minutes you can't do that. In those 10 minutes, I think as long as you address the red flag symptoms, show some kind of awareness that headaches can be disabling and just kind of address that a little bit in your history, I think you will be fine. And then obviously just finish everything else, so past medical, drug history, family history as well. So I've put recent flu-like illness because sinusitis can also present as a headache, and it often precedes like a flu-like illness as well, and it can last for several days. And it can be quite hard to differentiate it from a tension headache because it's, again, both sides of the head, and it can feel the same as a tension headache. Fine. And then you want to ask about high blood pressure specifically because it's a risk factor for subarachnoid hemorrhages, which is like a dangerous cause. So you want to ask them about high blood pressure and any previous family history of migraines. Drug history is also important, like I said, because if they're on a combined contraceptive pill, it can, first of all, increase the risk of stroke anyway, but especially if they have migraine with aura, there's a very significant risk of stroke, so you want to ask them about that. And then also there's something called analgesia overuse headache. So in patients who, let's say, have headache due to tension headaches, for example, if they use a lot of analgesia, they will basically have a refractory headache, so their headaches will not respond to analgesia, and the headache's actually made worse by all the paracetamol they're using. So you want to ask them exactly what kind of analgesia they're using and how much they're using. There's no real treatment for analgesia overuse headache apart from like trying to get off the analgesics slowly. Then you want to ask them about family history of migraines, because if it's like a first episode, the patient, so the patient herself or himself might not have a past history of migraines, but if the pain feels like a migraine kind of pain, and if they have a family history of migraines, it is possible that this could be their first episode, for example. So that's important. And I've put AVMs there. So AVM is arteriovenous malformations, and again, this is a risk factor for having a subarachnoid hemorrhage. So it is something that you would ask if you're suspecting a subarachnoid hemorrhage. I would not go asking this in your OSCE settings otherwise, because it would just look out of place. But if you're suspecting a subarachnoid hemorrhage, you could ask this. And if you could just say, have you heard about this? Because often, if someone in the family has the AVM, then it's likely that they may have heard about it. So it's worth asking. And then social history, very important. So things like alcohol, smoking, because again, like we said, cluster headaches can be made worse by alcohol. Some people might even use alcohol or smoking because the headache is so disruptive to their lives. Then you want to ask them about the occupation, and is it stressful, and how is the headache affecting their life, and all that, like we said. And especially the living situation is especially important if the patient is elderly, because again, if they are falling all the time, if they're at risk of falls, and if they're living alone by themselves with no carers, it's something you want to think about. So is it safe? Because especially if they're old, they may be on warfarin, they may be on rivaroxaban, and if they're falling all the time, it's just a bleed waiting to happen. So it's something that you want to bear in mind, especially if the patient is elderly, and kind of think about, does the patient need a package of care? Fine. That's a very thorough history. Like I said, again, important things are red flags and just covering the main points of the history. Don't worry about not asking all the questions. All right, coming on. So I kind of missed the examination, but in examination, what you're looking for is if you do a full neurological exam, so upper and lower limb, you're looking for signs of focal neurology, which would point towards a brain tumor. Okay, you're also doing a general exam to look for signs of meningism. So that's like a stiff neck. You want to examine their neck. And then you will have to do an eye exam as well. So that's called a fundoscopy, where you look at the back of their eye. And this is to look for papilledema. Papilledema is a sign of raised intracranial pressure. It's often actually, it's a late sign, so but it's just something you would do for the sake of completeness. So that's fundoscopy to look for papilledema, a neuro exam. And then I've put, so again, like you see, I've divided the investigations like I've always told you to do. So I've put LP. So a lumbar puncture is important if you are suspecting meningitis or encephalitis. So if the patient has fevers, has had travel abroad, has had a headache with, let's say, a rash, you would do an LP. To be fair, if they have the headache and the rash and everything, you would also start them on antibiotics straight away. So meningitis is actually one of those things where you don't wait for blood cultures before you start the antibiotic. You would start them on the antibiotic straight away before the blood cultures, because it's so dangerous. And then for subarachnoid hemorrhage, you could also do an LP. It has a greater sensitivity than a CT head. The only catch is you have to do the LP after 12 hours after the onset of symptoms. So you're looking for something called xanthochromia, that is xanthochromia, xanthochromia, and that's basically a breakdown product of blood. So it's bilirubin, which you can see on an LP. Fine. So that's your bedside investigations. And then coming on to bloods, you could do just a basic full blood count to look for inflammatory markers such as white cell count raised. You can do a CRP and ESR as well. So ESR is particularly useful for temporal arteritis, okay? Because it is a vasculitis in the end. So yeah, ESR is useful for that. There's not that many bloods for headaches. Obviously, if you go to like a neurology clinic, there'll be a lot of specialist autoantibodies that you'll have to order. But yeah, for your GP land and A&E, I think it should be just basic bloods. Imaging-wise, CT head is important for a headache, especially if you're suspecting a space-occupying lesion like a brain tumor or any other vascular causes like we spoke about. But yeah, just important to remember that you cannot rule out a subarachnoid hemorrhage just based on a negative CT head, okay? So you would do the LP if you're suspecting that. Okay, perfect. I'm just wondering if we should take a pause for questions at this point. Okay, I'll just finish the next slide and then we can do questions at the end because there's just one more slide. Fine. So I'll just quickly go through management of subarachnoid hemorrhage just because in my experience it's something that I've seen working in acute med, so I just thought it would be useful. So management of SAH, the main principles are firstly you want to give them analgesia, very important, don't forget. Even though it's a dangerous condition, the patient is in pain, so give them analgesia. And then you want to discuss with neurosurgery straight away, okay? So now this is before, I mean, if you're suspecting, because if the history sounds typical of SAH and everything, you want to at least make them aware of the patient. The options are coiling or clipping, okay? I won't go through it in too much detail, but essentially, in majority of the cases, they can just kind of coil the aneurysm, so they don't need a craniotomy. In some cases, they may need a craniotomy as well, but mostly it could just be coiled. So yeah, and fine. And then while you await the definitive treatment, so that's surgical, you have to kind of make sure that they're on strict bed rest. You're controlling their blood pressure. So this is on the medical ward. You would be doing these conservative measures, and and then there's also some evidence for starting nimodipine. Now this is a calcium channel blocker, and you would take this for 21 days. Well, the patient would take it for 3 weeks, and it's to basically reduce spasm of the cerebral artery and to prevent a stroke. Okay. And then after they've had the surgery, so it's very important to identify the source of the bleed. So it's important to know where the bleed came from. So you would do a cerebral angiogram to find the source of the bleed, and it's usually an aneurysm. These patients can often be very unwell, so they can often even go to ITU. And so it's very important to recognize the subarachnoid hemorrhage. I'll just recap it once more. So it's basically pain worse at the back of the head. So it's occipital headache, worst headache of their life, and it comes on suddenly. If they have any other features, I would say definitely talk to your seniors and make sure that they get a CT head and LP. Perfect. So that's headaches, in half an hour. If you have any questions, if you guys could just ask the questions now and I'll try to answer them, and then we'll do some practice. So we'll use Zoom like we did last time, and you guys can take a few histories amongst yourselves as well. Perfect. So